Thank you. Our next speaker, Dr. Vijay Baskar.
Recording
Nori, sir.
stopped.
Dr. Vijay Baskar, sir, from Viska Imaging, Hyderabad, will build beautifully on what we've just. He will take us into the world of AI-powered CT angio, especially CT-FFR and automated plaque analysis that will transform how we assess coronary anatomy and physiology.
I thank Dr. Raghu and team for giving me an opportunity to share some of my experiences on AI in CT angiography. I see a lot of friends here. I acknowledge everyone here, all the cardiologists, all the friends. I acknowledge all of them. I asked ChatGPT to make one slide and AI made. So we have been doing AI in presentations, but let us see the hardcore AI in diagnosis. So that also I'm going to show you. This I have shown to my colleagues. Will AI replace the radiologist? Yes, AI will replace the radiologist or anyone who don't use AI in the future. So AI is a part of us and we have to keep using it. There's no other option. Then what AI needs is validation and supervision, and AI is not always accurate. And in future this slide is meant for radiologists, but for everyone, faster throughput, and you need to cohabit with AI. There's no other option, and better make it surrender to you than you surrender to AI. That's what I feel. So once AI comes, the imaging has become now from gatekeeper to a roadmap for PCI. And what we call it as total coronary intelligence, that is one CT coronary angiogram can give you anatomy, can give you physiology, can give you plaque biology, total plaque quantification composition, can give precision with automated stenosis quantification and plaque quantification, and CT myocardial perfusion, which is coming in a big way. I'll show you some examples. I started doing CT myocardial perfusion with adenosine, rest and stress. I'll show you some examples on that. So, AI-assisted CT coronary analysis is advanced non-invasive computational cardiology, we call it. Exact degree of stenosis, functional impact on blood flow, CT-FFR, total plaque burden, high-risk plaque characteristics, AI-driven automated quantification, and of course, CT myocardial perfusion. So why automated stenosis quantification is more useful than visual? Our eyes and the human brain has a fatigue, but machine does not have a fatigue. It is known to give stenosis quantification a certain algorithm, number one. I start measuring as a diameter stenosis or area stenosis, but machine makes pixel level stenosis. The difference is that. Now, I'm always fighting, is it diameter or area? What should I call? No, machine is taking pixel level. So pixel level is more accurate than diameter or area. So, of course, now again, in the previous session and now what I am talking is whatever goes in comes out. You put garbage comes out. So ultimately, the quality of study must be important. Either in cath angio or in the CT angio. If quality of study is good, automatically. And that is why the number game, 64, 128, 256, 512, 640. The number game is useful because you have higher number of CT scan, better the quality of image. Better the quality of image, better the confidence level. So that is what is the number game about. Then CT-FFR, of course, is a very great tool. I started doing, we've already crossed about 1,000 cases on CT-FFR. There are some ups and downs in CT-FFR being non-invasive, and any modality non-invasive, if it reaches 0.8 to 0.85 ROI curve, I think it's fairly good enough. 85% accuracy is fairly good enough because it's a non-invasive test and you can't expect 100% accuracy. So that is more than enough. And the advantage of the AI-based CT-FFR now, you understand that FFR earlier, 6 months back or 1 year back, was sending to heart flow. Heart flow used to take 7 days. So now FFR, I'll show you, online I'll show you how I do it. Takes few seconds. So that is on-site FFR. So on-site FFR, by the time the patient comes out of the CT scan suite, you are telling him your FFR is this, so the vessel FFR is this. So that is the accuracy. Quantification of stenosis and FFR is being told as the patient is coming out of the CT scan room to the waiting room for the mandatory waiting to prevent contrast reaction. We are telling him that this is your FFR value of an vessel. So that on-site FFR have come now because of AI technology. Earlier, heart flow supercomputing used to take hours and days to give computational flow dynamics. Now AI has picked up from computational flow dynamics. It has kind of, machine learning. It has taken about 1 lakh cases of computational flow dynamics, analyzed the data, and based on the data, it is giving faster results. So AI we are using there also. So that's an advantage of AI there. So this theme being AI conference, I'm trying to insist more upon AI. In acute MI, of course, AI has a role. I'll show you, not very great role as on today, but AI in general in cardiac radiology has a great role. And this is what I told you about heart flow and the on-site CTA processors. Heart flow needs a big supercomputer, whereas the on-site CT-FFR analysis need a workstation or a computer. A computer of a recently good configuration will give you a good FFR value. That is what is the computational flow dynamics about. So things have become faster, and now CT-FFR, including CT perfusion, can be given as soon as possible, probably within half an hour to 1 hour. Then, what is coming big is automated plaque quantification. So you are giving anatomy, you are giving physiology, you are giving plaque morphology, biology, and quantification. So what I was told now by cardiology friends and recent conferences is that it is not stenosis which is not being much talked about. It is more about plaque burden and the quality of the plaque. So even in CT-based PCIs, what Dr. Usar and we discussed about CT-based PCIs, the quality of the plaque, the quantity of the plaque, the density of the calcified plaque, location of the calcified plaque, all of them matter in choosing your hardware. So again, the plaque is what is most important, and the AI is going to help you in quantifying the plaque, telling you how much plaque burden is there, number one, that is for PCI, number two, for any modifying treatment, or plaque modification treatment, and number three, assessing treatment response. For all of them, we have an objective parameter of, I can say that the calcified plaque is 70%, non-calcified plaque is 30%. Among the non-calcified plaque, 20% is a fibrofatty plaque, 10% is a fatty component. So that is the kind of AI discrimination we are trying to make. So everything again, thanks to AI. So like I told you, traditional classification of CAD from 50 to 70% stenosis to non-obstructive versus obstructive plaque. So I believe treatment is going more towards plaque and less towards stenosis quantification. And this is a very good article by Jagat Narula and Jim Min about, are we ordering the investigation in a different way? Because you see the plaque is occupying more space, stenosis next, and then comes ischemia. So we are running towards ischemia, but we are forgetting about the plaque, which is a major burden there. So I think this is what is coming in future. I stand corrected from all of you. You are a learned cardiologist, so you can show me, you can tell me the correction about it. Then of course the famous PROMISE trial, which talks about non-obstructive CAD and major cardiovascular events occur in patients with non-obstructive CAD, and they found that it is not 80% lesion which is causing the acute MI, but it's the 40% lesion causing acute MI. So again, the role of plaque. And in CARDIACS 2, again a modifier has been added for plaque burden, and we always have to qualify the plaque burden, tell them P1, P2, P3, P4. P4 is extensive, large amount of plaque burden, which again modifies the treatment in CARDIACS 2, acute plaque. Then plaque quantification severity has been given based upon the plaque volume, total plaque volume and percent atheroma volume. And if percent atheroma volume is more than 15%, then it is severe plaque volume, and these patients too bad. And it has been found that if the percent atheroma volume is high, they have MACE in the near future. They are more prone for major adverse cardiac events when compared to the plaque atheroma volume less than 5%. Like I told you, new emphasis is now on overall plaque burden and high quantification. And quantitative plaque analysis is quantitative and qualitative. Now qualitative is a high risk plaque. CT scan is a gold standard. OCT is also useful there, but for what the patient pays on a CT angiogram, if I can give you that it's a high risk plaque, more than enough. I mean, it's good, very highly accurate. So we can quantitatively and qualitatively give plaque. I can tell you about high risk plaque, I can tell you about calcified and non-calcified plaques. So that is again an advantage of a CT scan. So let us look at this young male, strong family history of CAD, no cardiac symptoms, no risk factors, came to rule out CAD. You can see that is the LAD, and in mid-LAD there are dense calcified plaques. I don't see any non-calcified plaque, they are all dense calcified plaques. Now, quantification of plaque, you can see here that the calcified component is 61% here, non-calcified component is 30% there, low or fatty component is 1.1, very, very less. That's a stable plaque or definitely a calcified plaque. And the automatic stenosis quantification I have got here, diameter stenosis 58.58 and area stenosis 74.47. In addition to pixel level quantification, the automated quantification also gives you diameter and area stenosis quantification. So what the machine does is accurate as long as your data is accurate. When you give a good quality data, you get the results are also very accurate. So you can depend upon the data, but you have to fine tune. Human intelligence comes there to fine tune the data there. You can use this data to your advantage. So this being a 50-70% stenosis, we did FFR and we found that FFR was around 0.84, CT-FFR 0.84, and the same thing we cardiology colleagues, and they said nothing to be done, medical management. So here we have completed a circle there that patient has calcified plaque, we gave a calcified plaque volume, we gave stenosis, and we gave physiological assessment. Let's see one live case how we do it, a case from today. If I can do it from here, I'll be very happy. I can do it. Today, this is today's case what we have done.
Does the calcium burden interfere with your FFR?
That's a very good question. There are two models. A well-trained model with lot of calcified plaques background in the background study as a source data will account for the calcification and then give the pressure values accordingly. So everything depends upon the software what we are using. So, but having said that, calcification definitely interferes with CT-FFR values, number one. Heart flow says more than 1000 to 1500 H. How should calcified calcium score? Don't do FFR. Heart flow has a limitation there. It says more than 1500. Don't do FFR because reasons go for a toss. I can show you an example also. I can show you an example, live example I can show. I'll show you that. I'll show you that example also.
One more thing, Shashi, what I do is if the calcium score is very high, I increase the, what we call the volt output of the machine.
I'm not seeing live.
We increase it to 120 to 140 kV, you get a good image. So in that way I don't know what Vijay Baskar calculated. No, for the CT. When there is a high calcium score, there is not
computer login
angiography.
Very computer login
So
screen
generator output
Any
to
difference
120
is-
to 140
Do all radiologists do that?
Yeah, our radiologists, we tell them. We told them that you go to 120, 140, you get a good image.
Yes, that's a very valid point. What happens is when the calcium is very dense, we have to use a high kV technique to go through the calcium and look beyond the calcium. So that is definitely followed in many places. Now again, with AI-based CT scan machines and CT scan computational techniques, the machine automatically chooses about the calcium and it gives us the better quality images on the, again, now thank you very much. So this is the live I am showing you. This is the CT scan. I have connected to my AI server in my center and I am showing you live how I do it. You can see here the lesion in mediality. This is mediality. So I don't see a calcified plaque. I call it as a non-calcified plaque. Now we don't call mixed plaque. We call non-calcified, calcified or partially calcified plaques. I see a non-calcified plaque there. And my AI says that it is mild stenosis. Okay. Now I'll go to plaque quantification, plaque analysis. It is loading the data. AI server is loading the data. I am getting the plaque analysis there. It is reading the data. Now, it has shown me all the red flags, posture remodeling, low attenuation, napkin ring sign. And if you see here, low attenuation plaque, it is 34.3% is low attenuation component. Calcified component is 0. You can see that appreciated calcified component is 0. Non-calcified component is 49. Low attenuation is 16.8. Fibrofatty. And low attenuation is fat, actually fat. That is a dangerous fat. That is, volume is 34%, which is dangerous again. So, you are in addition to qualifying as a non-fatty plaque, I am sub-qualifying into fibrofatty, fibrous and fatty component. That is the advantage of AI. Now, once I have done that, my stenosis here, it says 34.64 and area is 48. So I don't mind getting an FFR here because when it's coming at the same price, why not? So let us look at FFR also for this. I'm not getting the FFR somehow here. Here, I know I'm calculating the FFR of the same case of LED, I'm calculating the FFR. I'm getting the CT-FFR value here. In middle eddy, I got FFR value of 0.82. So, this online, today's case I am doing in front of you, I'm calculating everything with the AI based technology. So, that is the advantage of AI in cardiology. So, then after having said all this, after talking about all this, let us also see where I can show you a perfusion study which we have done, stress perfusion we have done in this individual who is a chronic diabetic for 30 years, no symptoms, came as a routine screening for CT angio because his cousin was coming. I'll show you the angiogram picture also. I'll show the angiogram picture first. The advantage of the latest scanners with the AI technology is, in the same study as we do perfusion, we can do angiogram also. Because at any heart rate, at 120 heart rate also we can do a CT angiogram. And this is CT angiogram. You can see here, RCA, extensive calcification, LED, extensive calcification, moderate to severe stenosis, proximal to middle LED, LCX again, severe calcific disease, RCA you can see, extensive severe calcific disease, FFR was done, FFR had some issue. Let us look at the CT perfusion. We have done CT perfusion on same stress and rest perfusion we have done. And what AI does is, it gives me a separated set of here stress and here rest perfusion. I get stress perfusion, rest perfusion separately, and I can quantify the perfusion. And what we usually take in myocardial perfusion, CT perfusion, is any myocardial blood flow less than 100 ml per 100 milligram per minute of myocardial tissue is significant ischemia. We have that cutoff of significant ischemia, and less. More than that is not significant ischemia, based upon a lot of trials and studies. So I get a percentage here that anything less than 100 mb of myocardial blood flow is 2.35%. You can see here 2.35%. You can see here it is 2.35%. That means in the entire amount of heart, my myocardial blood flow for significant ischemia volume, myocardial volume, is only 2.35%. That means there is no reversible ischemia. So there is no patient does not have any reversible ischemia features. That means no significant ischemia. I will not say reversible. There is no significant ischemia. Adenosine. IV. Same protocol as MRI or nuclear medicine. Same protocol. So we put the patient, do a calcium score. After calcium score, if the patient did not have coffee and other things which are readily prepared, we give adenosine for about 140 micrograms per kg for about 3 minutes. Then do the contrast study. Do an angiogram. That is the angiogram what you have seen. Then we do a rest angiogram after 5 minutes. So we compare rest and stress perfusion, and I get these results. So this is a perfusion which is showing increased blood flow in the myocardial segments. Rest, when compared to rest, there is increased blood flow, and these are areas of ischemia, and I quantify the ischemia as significant or non-significant ischemia. So that is again AI based technology for CT perfusion. So we have drifted away from.
So but in this case only 2 is
Exactly.
so
And
much of calcium.
with so much of calcium. And he went for a stress thallium, and stress thallium report is no significant ischemia in all three territories, no significant ischemia in all three territories. So the lesson I learned from there was heavily calcified vessels, chronic diabetic, no matter FFR was 0.6 and 0.7, perfusion did not show any significant ischemia.
Yes.
Yes, ma'am? FFR is wrong. FFR is wrong. What Shishikanta asked me the question. FFR has limitation there. So in heavily calcified vessels, his calcium score was 1750. So in heavily calcified vessels, FFR went for a toss. Myocardial ischemia, there is no significant myocardial ischemia on CT perfusion. Same thing was ratified by stress thallium that he did not have significant myocardial ischemia. So, and if you see the CT angiogram, it looks very grotesque. It shows as if there are multiple severe stenotic lesions. So, calcium has it's a double-edged sword. We don't know when it fools us, when it kind of lets you down. So, that's a big, tricky question. Calcium can be very thin, and we can go through the calcium. But calcium can be very dense, and it can block your analysis. So, these are some pitfalls on the CT scan. So, let us come back to my presentation now. I think I'll not go into the Can you show me PPT, please? Achha, that got switched off. I got it. So, achha, it came from beginning, okay. Now, this is a 74-year-old male, diabetes, hypertension, strong family of CAD, recent CT coronary calcium score of 1185, previous CT calcium score done 7 years back is 500, has atypical chest pain. We have done extensive calcium in proximal LAD. He was going abroad. He wanted to be sure. We did a CT angiogram and we have shown calcified component, and then we said CT-FFR was 0.83. He wanted to be very sure. He went and did a cath FFR, and you see the cath FFR report there as 0.83 with adenosine 0.83. So there are instances when AI-based CT-FFR is very useful, especially in moderate lesions, 40 to 70% lesions, even with calcified plaques. Because as a matter of fact, CT-FFR is very, very useful for moderate lesions with calcified plaque rather than extensive calcium. So this is one case where cath FFR with adenosine and CT-FFR were almost equal. So both were the same level, 0.83. So that is one example of trying to tell you about the CT-FFR. Then 64 male, diabetes, hypertension, asymptomatic, came for screening CTA. You can see that there is a high risk plaque in middle AD. Here you can see there is a high risk plaque here. This is the high risk plaque there. So we quantified the plaque and we told them what are all the high risk features of the plaque. So and then FFR 0.72. He went ahead. Went ahead and stenting was done. So you have one more tool, one more armamentarium in your hand to assess the physiological significance of stenosis, number one, quantify the plaque and then qualify the plaque. And of course, with myocardial perfusion coming up, we can tell you the myocardial level also. From angiogram to calcium to FFR, you're looking at only the blood vessels. Now with myocardial perfusion coming, I can go up to myocardial level, myocardial level, that means perfusion level, and tell about the coronary reserve, whatever reserve, how much reserve, myocardial reserve, how much is there in the myocardium on the CT scan perfusion. And let me tell you, all these non-invasive tests have about 85-90% accuracy. So we can reach only up to that level, not beyond that when compared to the other things. So this is what is about. And then in acute MI, this is a very busy slide here, but chest pain evaluation, impacts at every session, protocol selection through final clinical decision making. do a high sensitivity troponin, elevated STMI, immediate cath lab, non-STMI, risk stratification, negative borderline, CCTA, A analysis. Here A analysis is coming. Intermediate stenosis, do CT-FFR and then follow. So AI is there at every level in assessing one of the algorithms assessing acute MI. So we'll not go into these details. The practical implications of AICT in acute MI are number one, it is not recommended. Number two, it is recommended only when patient has chest pain, intermediate lesion, not in cardiogenic shock, and not a candidate who is supposed to go to cath lab for stent placement. So in those people only try to play around with CT and CT-FFR. Obviously, any acute MI has to go to cath lab first and not for a CT scan. So those intermediate chest pain lesions, they come, and then in those individuals, Scott Hart trial have shown that you can identify the high-risk plaque, prevent major adverse cardiac events in a couple of years, and then also predict which patient develops MACE events, and then which patient behaves worse depending upon the plaque morphology and plaque quantification. So that is what is about CT scan. Now, a lot of research is going on enabled coronary plaque quantification outperforms traditional risk scores. Then radiology embraces FFR, CT and AA plaque analysis as cardiac imaging evolves. Everything from latest journals, latest articles in 2026. CTCAG has undergone a paradigm shift from anatomy-driven era to physiology and plaque-driven era. Anatomy plus FFR plus plaque plus stenosis is comprehensive CTA. Now, perfusion is coming up in a big way with CT perfusion. I think we are there in acting as a one-stop shop in trying to give anatomy, physiology, significance, hemodynamic significance, and then at myocardial level, what is the coronary reserve. So that's what is ordered. And artificial intelligence is transforming the coronary imaging, precision, automation, and prediction. Future directions, you can do a virtual FFR guided stent implantation, and you can virtually implant a stent on the software and look at the pressure difference distally, whether it's making a difference or not, whether it's successful or not. So that is coming up now, very big way, virtual stent implantation. CT and IVUS image fusion, fully virtual PCA planning. Of course, there are limitations, like I told you, garbage in, garbage out. So study must be good. Only then your quality, your whatever you're getting out is good. And AI accuracy versus accountability. AI provides numbers. Radiologists or the cardiologist provides responsibility. Legal and ethical accountability still lies with the human data, that is us. I can't say AI has done wrong and escape with it. I have to take full responsibility for AI, whatever is giving me, right or wrong. If I enjoy the fruits of AI labor, I should enjoy, I have tried to take its disadvantages also with the same spirit. So AI is decision support, not a decision maker. That is very important. It's only decision support, not a decision maker. Man versus machine and practical perspective, AI identifies anatomy and physiology. Cardiologist decides revascularization. Shared decision making platform. CT is augmentative, not a replacement. So that is what is today. AI is a tool, not a competitor. Best results come from collaboration. Future cardiac CT is man with machine and not man versus machine. Thank you very much for your attention.
Many people laugh. We are dominating.
You should not dominate only in the cath lab.
Very good.
Yes, sir, Vijay.
Yeah, we have over 30,000 CT coronary angiograms in the cloud, and 2 years ago we started CT-FFR and plaque morphology. The story of CT, cardiac CT, coronary CT angio, started with calcium score in 1990. The paper was rejected initially, and then finally accepted the role of calcium score. Then in 2011, it was the Discover Flow trial, which has subsequently 10-year follow-up, where they have shown that CT-FFR is equivalent to invasive FFR. Then the next trial was in 2012, de facto trial, wherein because of the poor quality of the image, the primary objective failed, and then the NXT trial was initiated. The NXT trial with good imaging with the nitrates, sublingual nitrates in 100% of the people, and 1.4 version of this heart flow. With that, it was established that it is equivalent to invasive FFR. So that is proven. Then in 2014, 15, 16, they have tried comparing with the functional studies, the anatomy and functional studies, the Pacific trial, the SPECT, the PET CT. They compared vessel-specific and patient-specific, wherein it was shown that CT-FFR is equivalent, if not superior to PET CT, when you exclude the evaluable lesions. That was about 25%, but not as garbage in, garbage out. Here he was mentioning, sir is mentioning, quality of the image is very important. So that showed that, okay, the stress test, it is better. Traditional risk factors, it is much superior. And then came the clinical trials where they have followed for over 10 years, the Scott Hart trial, the PROMISE trial, where it was shown that clinically you do the traditional stress test, invasive angio and all. And then subsequently for in several lakhs of patients, it is known now that stress test doesn't add any more information. It should not be a guide to do the invasive cath angio, because more than 60-70%, it doesn't lead anywhere. So now it is pushed down, not as the first line of test. And then the most recent data, as Shah is mentioning, the advanced registry, then fish and chips, that is UK study, NHS study, 90,000 patients, pre-CT-FFR era and post-CT-FFR era, 50,000 and 40,000 patients roughly. It is shown that there is clear improvement in the outcomes 2 times, especially if the CT-FFR is less than 0.50, double the mortality, and also the the myocardial infarction. And then the decode, the reveal plaque, all these now P3 and P4 trials, wherein the IVUS imaging and OCT also was tested. We have 27 cases where we have shown the CT guided PCI, how now we calculate the calcium arc, whether what you need to break it, whether it is thick, thin, and rounding, 180 degrees, 360 degrees. And then length of the stent we will assess, and then we have measured in the OCT also. Now to measure the stent size, dimension, length, you don't need OCT now. We have cut down significantly the IVUS and OCT. Only when you feel that expansion, maybe because of the, positive remodeling, or when you feel, then after the stent, we are doing OCT to do further stent expansion. Otherwise, it is shown that IVUS and this CT imaging. So now with the P4 trial, people are now doing precise the heart flow. That is another heart flow study where they are doing exactly looking at the FFR, then the plaque morphology, and making a clinical decision, therapeutic decision, how it is going to affect the outcomes in the long run.
Yeah, I just want to add just one point, sir, here. We are not taking only, adding to Dr. Ramesh, we are not taking FFR only as the guide for suggesting a treatment or whatever it is, because I have found as recently as yesterday that there was a severe lesion with a very dirty plaque. What I call dirty plaque is a high-risk plaque, which has high propensity for posterior remodeling is 2.4, which is very high propensity for embolization. His FFR value was 0.8. So in spite of which, I suggested that he should go immediately to cath lab and get a stent done, because the stenosis was very severe. And thank you. You can continue.
Yeah, 2 points. One is in response to this. I simply could not resist. FFR is the best way of picking up whether there is ischemia right now. Whether the lesion is going to break down or not, no technique in the world is able to tell us, right? Astrology is better than we are, right? So it's important not to prejudge. Even if it has high risk, if you break them into 2 groups, one group you do stenting, for all the other group you give them aggressive medical management, there is no proof that there is going to be any great difference in outcomes, because in one group the end point, that is stenting, has already occurred, right? You have already stented, and the number needed to treat to prevent one event maybe approximately 35 to 40. If you're going to place 40 stents to prevent one event over the next 3 years, I think we have to think very hard in what direction cardiology is moving. Second point, what Dr. Ramesh said is absolutely right. In today's world, I have spoken to the primary investigator of P4, Charles Collet, and everything is, they're actually going to come out with the results in about a year, which is a CT-guided angioplasty versus an IVUS-guided angioplasty, and this is the first randomized data. The problem in this group is one small subgroup in which after you finish preparing the lesion, whatever predilatation you do a balloon, you do an atherectomy or whatever, based on what you have decided on your IVUS oblique your CT scan, the problem is the lesion sometimes extends. And they're having a little difficulty in putting which category to put this. Is it an endpoint or not? Because if you have a 20 millimeter lesion, you decide to put a 23 stent, you prepare it, and then when you do an IVUS again, you find that you have hematoma at both ends and you have to extend the stent to about 30 millimeters or so. They've not yet decided what to name those events. Is it a failure of the CT? Because the CT said, you've got 23, but now you've got 30. But this has occurred because of your aggressive preparation. So we don't know which category to place them into, and that is a significant number, especially in complex lesions which they're trying to see. So, but I think the world is moving towards more and more non-invasive classification of lesion. There are 2 studies also which was erosion 1 and 2. So in erosion 1 and 2, patients with ACS were sent for CT, which took about 5 minutes, and then sent to the cath lab. And then the procedure was done, and then they virtually planned what they would do on the CT and compared with what was actually done. And there was about a 25% difference between the two. That means what the CT said and what they finally did, they were different. And that's why they did erosion 2. And we tried to be part of erosion 2, but because of certain international restrictions of the quality of images, we couldn't be part of erosion 2. But it did show that there is a significant place in smaller areas where an immediate cath lab is not available. Even patients with suspected ACS, not true ACS, probably in suspected ACS, it might actually help us to get out of trouble. Even if you don't have somebody to analyze on the spot, you could actually do the CT. Within 10 minutes, it can be sent onto the cloud. It could be analyzed by 24-hour people, and they could give good and validatable and reproducible results in that group who didn't have high-risk ACS. So this is not about STEMI. This is about patients who are at intermediate risk and who have possible ACS. That's the term that was used.
Yeah, just one aspect is slightly it is other way around, sir. See, in invasive cath, you are trying to fix the lesion by eyeballing or measuring, whatever. Then the virtual PCI planner, what you have, if you do the pullback pressure, if there is a step up, that is a focal lesion, number 1. Number 2, if it is diffuse and if the delta FFR is not more than 0.12, it is unlikely to help. The stent is unlikely to help. Similarly, even for putting a graft, now CABG, you cannot see the plaque below that discrete plaque, whereas CT-FFR can measure. So now they are revising the location, where they have to land the graft. This is another factor. So lots of things, I mean, and then with CT only now people are taking for emergency CABG, no need for invasive cath. Likewise, I think P3, P4 trials and all, there is now, more than lack of patients where data is there for CT-FFR and plaque morphology, as sir is mentioning, as dirty lesion, 0.8 to 0.9, Dr. Sujata was mentioning in the morning, prevent trial. So here, even if it is more than 0.8, people say that if it is more than 0.9, it is almost very safe. If it is less than 0.6 or 0.5, definitely have to address it. These are the 2 things. But between 0.6 and 0.8, clinical picture, the other aspects, the plaque morphology has to be taken. And then the post-PCI, the FFR, virtual, simulated, if it is more than 0.90, it is likely to do well. On the other hand, if you do it and if it is less than 0.858, stent is going to likely to fail. So this is all the data coming up with huge follow-up data now. I think that's it. Yeah.
Recently, there was a lot of backlash on Twitter that FFR itself is on shaky ground because there is
Yeah, you're right. But that is with regard to invasive FFR complications. So whereas this, there is a lot of data, and 90,000 patients fish and chips is a very standard example. And then the advanced registry, all these have shown with several thousands of patients. That is 10,000 patients. So likewise now, see, the arguments and all, people laughed at calcium score and cardiac CT for almost 10 years, 12 years. But now you have, this is a science based, and then now mechanophysics, everything is now physics. So there is follow-up data for 10 years. If you see the discover flow and the coming up data, all these things, we depend on data. We have been working on trials where the confounding variables are so many, and AI is not there. AI was not there. We were just segregating the patients. Now AI, 600 parameters you can measure to segregate and to have more precise clinical trial data and segregation, and then even the follow-up and all.
AI had this issue, sir. Heart flow was a monopoly, and because of heart flow monopoly, the FFR was very expensive. Yes. Now, if I am doing a CT angiogram at 12 or 15,000 rupees, I am giving you plaque quantification, give FFR. Why not? Where is the cost? And I am giving you in minutes. So we use it for our better advantage. When heart flow was monopoly, it was there. So there are a lot of papers which said, because to counter heart flow was taking 1 week, very expensive. Is it really useful to do an FFR if you can do a stent for the same money? But now the things have changed. It is available. FFR is available everywhere now.
It is reimbursable. In Japan, they have started reimbursing in 2017, yes. And then they have shown that it is Japan CT-FFR trial, likewise, and almost everywhere now it is.
Thank you, sir.
Thank you, Dr. Vijay Baskar. Thank you.
65% of the lesions what you see in cath lab are intermediate lesions, and 30 to 40% of lesions are